we're looking forward to a spirited 30 minutes after these presentations as well. But I'm delighted to introduce our second speaker who has assumed the podium, and that is Laura Logie, who's the Director of Research at Nueva Vida. Her bio is in the materials, and she's going to speak to us about what does patient engagement look like to marginalized communities. Thanks, Laura.
Thank you, Rich. Good afternoon.
Good afternoon.
Good afternoon. It is after lunch, I know. I want to thank Q. This is my first Q conference, and in the last 4 or 5 hours, I just want to share how much I've learned about Q. And I also want to talk about that a lot of what the speakers have said, I may be repeating. We've heard about preaching to the choir and so on, but I'm also thinking that some of the strategies that I am going to talk about may be new approaches to some of us. Because this panel is actually called something like, let's start over, right? Or something like, let's start over. So if we have that kind of in the back of our mind about ways of thinking about things and let's starting over. I feel I have a unique perspective because I've worn 2 hats. My first hat was faculty. I was an academic researcher for 20 years at the University of Maryland. My second hat is Director of Research in a community-based organization. So academic researcher on this side, community-based advocate on this side, gives me this kind of unique perspective. And I've learned a lot about some of the mistakes I made as an academic researcher. I'm learning about some of the mistakes and pitfalls as a CBO advocate. And I'm also learning about some of the lessons learned that we can bring back to this. As an academic researcher, I would sit in my ivory tower, in my desk, and I would just feel like there were so many marginalized populations that were just dying to be part of my research study. How could they not be? It was the best research question. It was fantastic. They should be knocking at my door. On the other hand now, as a community-based organization advocate, I feel like I've suddenly become this bulldog or this pit bull. And I get these calls from academic researchers and guideline development groups and people that want us on patient advisory boards. And I'm like, whoa, whoa, whoa. Who are you? What do you want? How do you want to talk to my patients? What exactly is your need? So I think we're going to talk about some barriers and challenges specifically with my marginalized group. We're going to talk about possibly some effective strategies that I learned in a BCORI-funded intervention. And we're going to understand these kind of ways in which we can start over and highlight really the importance of this proverb here: nothing about me without me. Back to preaching to the choir a little bit. We've heard about this today, of course. When we're talking about engaging hard-to-reach patient consumers, stakeholders in research implementation, what do we know? Well, we know that effective patient-centered outcome research hinges on patients being interested and emotionally involved in the research guideline development being undertaken. We know that a period of pre-engagement prior to recruitment is essential in assuring comprehension and providing time for participation and discussion with friends and family. This is specifically important to the Latino family and Latino culture. We know that patient engagement in the planning and execution of research could improve its translation into clinical practice. And lastly, we know that there is an overarching ethical mandate for patient participation in patient-centered outcome research. But, and here's where the but comes in, how do we engage these hard-to-reach populations? How do we get them to come and sit on our patient advisory panels, our clinical guideline practices, our research question, our research studies, needs assessment, become part of the pre-engagement research proposal that we know is so effective? Basically, how do we get these hard-to-reach populations that face a myriad of challenges and barriers in joining you at your table? Let's talk about the table. We've talked about the table a little bit today. Here's our table. This is our conference room at Nueva Vida. Isn't it nice? Here's our table. We hear about patient representatives coming to our table, and oh, it's so important to have the patient's lived experience and the patient's voice at our table. I want you to think about transforming your way of thinking and realizing that that table is your community. Researchers should not be asking patient representatives to come to their table. Researchers should be realizing that that table is us, are the patient representatives, are the community-based organizations, and are the consumer advocate groups that we so desperately need. We know that hard-to-reach populations are way different than most of us here in this room. Vulnerable populations face medical mistrust. There's patient-provider communication problems with their physicians. There's fear of stigma, especially with immigrant groups as well. So if we want valid patient-centered outcome research, thinking of the table as a framework, my little table kind of like as a framework, where we should get a seat, should be something we should consider paying attention to. What are some of these barriers and challenges in hard-to-reach populations? Well, we definitely know medical mistrust. A long history of medical experimentation and abuses of racial ethnic populations has led to feelings of vulnerability, suspicion, and mistrust towards institutions of research and healthcare among these hard-to-reach populations. We're all very, very familiar with the Tuskegee syphilis study, whose sole purpose was to observe the natural progression of untreated syphilis in rural African American men under the guise of receiving free health care. Maybe a little bit less known, however, is the forced sterilization that occurred in 25 of our states. For decades, for example, California performed forced sterilization, and these occurred in part to immigrant families in California feeling that there would be a strain on the fiscal budget, and it was under the rubric of population control. Thus, sterilization, and for the women, it meant having their tubes tied, and this did occur with men too. Men were given vasectomies, were often coerced into signing paperwork which they did not understand, or were told that the forced sterilization procedures would be reversed. What did they have in common? They were not fluent in English. Who was the hardest hit? Spanish-speaking immigrants in this forced sterilization. Terminology. We've already heard a lot about terminology today. Even I'm learning words, right? Even after 20 years of being an academic, these words that we hear over and over. The word research in itself, outcomes. We're all talking about outcomes, variables, IRB, clinical practice guidelines, protocol, dissemination. What do these words mean? Well, can you imagine what they might mean to these hard-to-reach populations? In fact, the word research is very, very scary to vulnerable populations based on this medical mistrust. Decades of medical mistrust have made vulnerable populations afraid of the word research. So when I sat in my ivory tower and I wanted to talk to vulnerable populations about research, I did not realize what kind of connotations that might be. Another significant barrier and challenge, of course, is language. A recent study that was funded by RWJ found out nearly half of the Spanish-speaking patients consider language barriers their biggest challenges. As a community-based advocate, working in a community-based organization, I wholeheartedly agree with that. Our population is 98% Spanish-speaking. In addition to difficulty in understanding things about the fragmented healthcare system, difficulty in understanding insurance and costs, just about under half of the Spanish speakers in this report said that they had difficulty speaking with their doctors, and they had difficulty looking at any kind of forms. They also said that when they were offered translated Spanish forms, that they were hesitant to take it. Very interesting what this study found in terms of that. And that patients may actually be reluctant to ask for these resources in their own language. Because Spanish speakers do not always have access to these resources, they largely rely on their friends and family to translate and offer health guidance. Spanish speakers are twice as likely to listen to their family and friends than they are to English speakers. Social determinants of health. That's something we haven't talked about today. So one thing we need to understand is that there's logistical challenges as determined by the social and economic and environmental factors. Poverty, unequal access, low educational attainment, poor resource neighborhoods all contribute to low enrollment in research implementations. What else is missing is the research gaps. Huge gaps just in what I was trying to learn in the last week or two exist when we talk about patient engagement, especially in terms of clinical practical guidelines. Research gaps exist on the who, the how, and the when we're talking about strategies. Armstrong et al. Reported that no research exists regarding best practices for the how of obtaining patients' views or whether single strategies are sufficient. Research that's dedicated to identifying the best practices and methods to achieve engagement is lacking and clearly needed. One area where I did begin to find some of the research on patient engagement is the gray literature. So a possible strategy might be for us to go ahead and look at that gray literature and see what our community-based organizations and advocacy groups are putting out. We did a case study funded by Bakori, and here's where I'm going to talk about some of the successful strategies that we learned together with Georgetown University Lombardi Cancer Clinic. Well, as we all know, I'm preaching to the choir, we need to build, maintain trust and respect, especially with the Latino community. So what are some of the kind of practical methods that we can think about? And it was alluded to before a little bit about patient navigators. What about a community engagement worker? We know that patient navigators, community health workers, promotoras, we know that they're very, very effective in terms of transforming the healthcare system. Community engagement workers that are bicultural, bilanguage, live and work in the community may be effective ways. We also talked about that if we really want to have patient-centered engagement, we need to go where the community is. And that does mean walking out of our desks, leaving our ivory towers, going to the churches, going to the community centers. We know also that patients are only if they're very, very motivated are going to go ahead and come to the offices. So let's go there. Fair financial compensation directly deals with social determinants of health. If you're poor, if you have unequal access to health, if you're living in poor neighborhoods, if you have no transportation, no money, no child care, there is no way that you're going to get hard-to-reach vulnerable populations to do anything in terms of research implementation. That's that. We really have got to do something about the social determinants of health to reach these hard-to-reach populations. And that's where that fair financial compensation comes in. And Bakori is actually very good about fair financial compensation. We know that class matters. The culturally and linguistically appropriate services. What about family presence policies? For the Latino families, for the Latino hard-to-reach populations, families plays a huge part. Nice and effective family present policies when family is always invited to that table, are part of that table, needs to happen. So now we're back to the table. There we are. Consumers, patients, researchers, we're all smiling, we're all happy. We've all learned about lots and lots of stuff. So one of the important things we learned about is that we need to recognize our power and privilege. One thing we haven't talked about as researchers and GDGs. Our own power and privilege in dealing with hard-to-reach conversations. I just end with this quote. I can do things you cannot, you can do things I cannot. Together we can do great things. And I think this is the way we need to think about reaching out to marginalized populations. Thank you.
Thank you.